Hello, everyone. My name is Brad Langford. I am a pharmacist consultant with Public Health Ontario, and I'm also a member of the Drugs and Biologics Clinical Practice Guidelines group at working group at the Science Table. So welcome to the Ontario Science Table webinar on medications for outpatients with COVID-19. So as you know, thankfully, the rates of COVID-19 are continuing to fall across the province as we increase the proportion of patients vaccinated against this virus. But we really need to keep vigilant and as we continue to see cases and new variants take hold like the Delta variant. So we appreciate you taking the time to join us and learn about how you can manage patients with COVID-19 from a pharmacotherapy perspective. We're very excited today to have three experts joining us, all of whom are members of the Science Table Drugs and Biologics Clinical Practice Guidelines Working Group. Dr. Kate Miller is a generalist, family physician, and an assistant clinical professor at McMaster University. Her scope of clinical practice includes primary care, maternal newborn care, and emergency medicine in both rural and community hospitals. Dr. Ullanda Niel is a family physician at the Scarborough Centre for Healthy Communities in Toronto. Her training and practice includes caring for adults with intellectual and developmental disabilities. Sumit Raybardhan is an board-certified infectious disease pharmacist practicing at North York General Hospital, where he also co-leads the antimicrobial stewardship program there. His research and practice interests include epidemiology, global health, and antimicrobial stewardship. So just move on to the objectives for our talk, which are fairly straightforward. So our aims are to provide some evidence-based recommendations on the use of medications for managing COVID-19 outside of the hospital setting. And we hope to arm you with some information to help you address questions and respond to some of the sensational headlines that are out there about the use of medications for COVID-19. And before I turn it over to the presenters, just a reminder or a note that this presentation will be recorded and it will be made available after the talk on the Ontario Science Table website. And our presenters today have no relevant conflicts of interest to declare. And so with that, I'll turn it over to Dr. Miller to get us started.
Good evening, everyone. So we want to just start a little bit with couching who we're talking about today, which is the mildly ill ambulatory outpatient. So when we look at all of the recommendations that we've come up with at the Science Advisory Table here in Ontario, but fairly broadly across clinical practice guidelines for the management of COVID, we classify them largely into three groups: mild, moderate, and severe, with the mild group being those who are ambulatory outpatient and not requiring supplemental oxygen. And then the moderately and severe groups are those requiring supplemental oxygenation and or organ support in the form of ventilation for the critically ill. So tonight we really are talking about the patients that those of us in primary care would see, or that you may be seeing and discharging home from an emergency department, who do not require oxygen in particular or hospitalization for other concerns. Next slide, please. Oh, Brad, there we go. So to just sort of give a little bit of a context to that, the type of patient that we're hoping we can help you with is like this family, a family of three who have now all just tested positive, have some mild symptoms, or in fact, in the case of the teenage son here, asymptomatic, who've received their advice from public health when they got the call that they were positive about isolation and protecting themselves. But Mrs. A has actually sent you a file of things that she got from some friends off of Facebook, some links to some YouTube videos she's really hoping you had time to watch, because she's heard that there are medications that can make a difference. You promised to review the articles, which is very generous of you in your limited time, and get back to her. So really what we're hoping tonight is that you can walk away with some answers to some of those medications that our patients might be moving forward, or those ones that you've seen the headlines of and are really wondering, is there something more I can or should be doing for these patients? Next slide. In case you're in a rush though, the long story short, Nothing works. So if you were here for that one trick that doctors don't want you to know to prevent severe COVID, we haven't got it because there isn't one. So we will give you a little bit of evidence around things that may make a small difference. Sumit at the end is also going to talk about some things that might be coming down the line in terms of future research. But by and large, what we know about trying to prevent progression of mild COVID to moderately or severe is that we've not yet found anything other than vaccination, which really works in this context. Next slide. But to start with a little bit of a moment of hope, not all pessimism, we will start with something that has a little bit of evidence of benefit, which is inhaled budesonide. So the headlines that came out in mid-April when this study came out, asthma drug speeds up recovery at home. Next slide. So the theory behind inhaled budesonide as a treatment for mild COVID is its anti-inflammatory properties. That's the theme that's going to come up again and again in the drugs that we're going to talk about tonight. It also comes from some observational data from very early in the pandemic that while we thought people like asthmatics might have more severe disease, they seem to have lower rates of disease than we thought. And so a suggestion that the inhaled corticosteroids that they were using for managing their asthma may not may actually be protective. So there are two trials in this regard, both of them out of the UK. The first one that came out was the STOIC trial, relatively small trial of 167 adults, all with mild COVID, who were randomized either to budesonide at its maximum dose, so 800 micrograms BID for up to 28 days, or resolution of symptoms, whichever came first, or to a placebo inhaler, or pardon me, or to nothing. So this was an open label trial, which means there was not blinding, there was no placebo. So patients were even given budesonide or usual care and discharged home. So that in and of itself creates a little bit of uncertainty about the results, as patients knew whether they were being treated or not. The other problem with this study that kind of makes the results difficult to interpret and act on was their primary endpoint, which was defined as urgent care visit, although within the preprint itself, they did not actually give a great description of what they meant by urgent care visit, although their follow-ups were those who had an after-hours GP assessment, an emergency room visit, whether or not that resulted in hospitalization. 11 people, or 15% of the usual care group, had the endpoint of an urgent care visit versus only 2 or 3% of the budesonide group, which gives you this NNT that looks really impressive of 8. So for every 8 people I put on budesonide, I can prevent an emergency room visit. However, when we look at the purposes of those visits in the 13 people who had a follow-up visit, well over half of them were not necessarily COVID-related things like rib fractures were in the group. And those are really small numbers. So if we take just 1 out of the usual care group and add just 1 to the budesonide group, you start to get to an insignificant change between the two. So really, because of small numbers, you can't really rely on that data there. And the other big challenge with this study is that they stopped the study early, not because they'd reached their target endpoint, not because they'd reached statistical significance and felt they could stop early because they didn't need to recruit more, but because this study was being run during the a really strict lockdown in the UK, and there just wasn't enough patients with COVID for them to do their recruitment. And no significant difference in some of the more big ticket outcomes like hospitalization or severe illness. So based on the STOIC trial, when our guideline working group looked at it, we were relatively confident that this was not good enough evidence for us to make a recommendation to treat. But probably about a week, 2 weeks later, the principal trial came out, again, a UK trial. This one a little bit bigger though, so 751 with budesonide and just over 1,000 usual care. Again, open label, meaning we don't have a control, or we don't have blinding here. And also really important to note that this is a selected high-risk group. So this was not all comers, but anyone who is 65 or over, or anyone who is over 50 who had risk factors such as diabetes, hypertension, or other predictors of severe illness. So a population with greater potential for benefit. Their initial primary endpoint was progression of disease, requiring hospitalization or death. But partway through the study, they realized they were not going to be able to recruit enough to make a conclusion on that. And so they changed their, they created a co-primary endpoint of time to clinical recovery as self-reported by patient. And they defined that as to first recovery, recognizing that there are some people who have sort of a biphasic or a long COVID kind of scenario. And they did find for these selected high-risk patients for that endpoint of patient-reported clinical recovery, there was about a 3-day faster recovery in the budesonide group. This study also stopped early for the same reason in terms of difficulty recruiting in the face of lowering COVID levels, and has some similar problems with its design to create bias. And we actually debated around this. So is 3 days faster recovery a significant patient-oriented outcome or not? But we have on the clinical practice guideline working group, there are some patient partners, so people who have recovered from COVID. And one of the patient partners on the group said that for her, 3 days easier breathing would definitely be worth it. So in looking at that, how do you take that? What do you do with this? I think you think about who the patient is, recognizing that this data is for a pre-selected group, not all comers, and may or may not apply to a healthy 20-year-old with no risk factors, that you're not preventing progression for disease, but you may offer some relief in symptomology, just like we would do for someone with a post-viral cough, and we may use an inhaled corticosteroid in that situation. But you have to remember that while these drugs are common, we use them comfortably all the time, they are not without risk as well. Recognizing cost to patient and system, all risk of complications such as increased rates of community-acquired pneumonia or thrush. And also, study came out at the peak of wave 3 when we were seeing 4,500 cases a day, which might have meant if all mild COVID got prescribed budesonide, we'd be writing 3,000 prescriptions for budesonide in the province of Ontario a day, which of course would create the risk of drug shortages for people using it for other indications. Next slide, please. I think in the questions, there was a question about whether or not a combo product like Symbicort, would that work the same as budesonide? Presumably, we can't say anything about whether the long-acting beta agonist would have any difference in there, but you're giving them the same overall dose of budesonide, just with a second agent with it. So keeping in the anti-inflammatory theme, we move on to dexamethasone. So dexamethasone, certainly one of the drugs with the best evidence of benefit and one of the first ones out of the gate. So back in June, dexamethasone hit the headlines as being the first life-saving drug in COVID, which for moderate and severe, I think we can call it that. But next slide, please. Sadly, for mild disease, though, we can't. So dexamethasone, again, a lot of the drugs we're going to talk about tonight are really tempting to prescribe. They're drugs we're familiar with. They're drugs we use all the time. I write a prescription for dexamethasone almost weekly for some indication or another. So we're comfortable with them. And that makes it really tempting to prescribe them here as well. But in the case of dexamethasone for mild illness, we actually don't have a huge body of evidence, but the body of evidence we have would say that prescribing it is not beneficial and in fact may have some harm. And the majority of that evidence comes from the recovery trial. So this is a large platform randomized control trial in the UK. It's going to come up several times because what a platform trial means is that you've got multiple arms ongoing at the same time. So they're looking at many drugs simultaneously. And dexamethasone has been shown to have a clear benefit on progression of disease, requirement for things like invasive ventilation, and death in those who are moderate and severe, meaning hospitalized patients requiring oxygen. Recovery is a hospitalized patient trial, so it doesn't have an outpatient population in it, but it is all hospitalized patients that are in recovery, regardless of whether they need oxygen or not. So the group not requiring oxygen within recovery gives us a bit of a surrogate population for the outpatient population, given that our definition of mild illness is those not requiring supplemental O2. And so in the case of the recovery trial, they looked at 501 patients who received dexamethasone despite not needing O2 and being hospitalized, and compared those to a group about twice as large who didn't receive dexamethasone, also not requiring oxygen. And they showed no benefit in progression of disease, requirements of O2 down the line, or need for invasive ventilation. But in fact, in the group who received dexamethasone, they saw a higher likelihood of progression of disease. So a signal that dexamethasone may in fact be harmful. I'm not sure that makes a lot of sense to many people, and I'm not sure how we explain that, but definitely no benefit, some potential for harm. And from that comes a clear recommendation not to use dexamethasone in patients not requiring supplemental O2. As I said, almost all the evidence for dexamethasone does come from this one big trial. There is one other really small randomized control trial and a couple of observational studies. So a systematic review has been done looking at all of those trials together and comes to the same conclusion that there is no benefit for the population that is not requiring supplemental oxygen. That does bring me to a small caveat, though, around using dexamethasone in the community, which there are populations that we may treat in the community and certainly have been treated in the community up until now that would meet the criteria for dexamethasone. So those are people who perhaps are already on home O2 for COPD, who have increasing O2 need, would put them in the group where you could consider prescribing dexamethasone, or patients in a long-term care facility, for instance, where you are initiating oxygen in that setting rather than hospitalizing them, or as we saw more in the US than here in Canada, at times of really peak demand on hospital usage, patients being discharged home from the emergency department onto a new start of home oxygen. So for all of those patients, it would be reasonable to consider prescribing dexamethasone, as they don't really meet our criteria for mild disease. They really fit the criteria for moderate disease. And the treatment then in that case is 6 milligrams daily for up to 10 days. In the studies, it was until hospital discharge. So if O2 is discontinued before the 10-day, you wouldn't complete out the course. Next slide, please. And then completing my anti-inflammatory triumvirate, colchicine. So this was the big headlines in January. Colchicine reduces the risk of COVID-19 related complications. So a really bold news release that came out saying it was great, an abstract that came out that wasn't as impressive. And unfortunately, what you'll see in a moment is a study that was even less impressive than the abstract. Next slide, please. So this study was COL-Corona. It's an international randomized control trial that was based out of Montreal. So Canadians were among the 6 countries that participated in this study from March through to the late fall of 2020. This is unlike recovery, where we're using a surrogate population. This is our target population of the conversation today, outpatients with mild disease not requiring supplemental oxygen. The study protocol was a bit of a weird dosing, 0.5 milligrams BID for 3 days, followed by 0.5 milligrams OD for 27 days. So a really long course of treatment. And they closed their study at about 75% recruitment. Again, not because they had recruited enough patients to meet their endpoints, but for logistical issues, ran out of money, ran out of time, were unable to continue recruiting for a variety of reasons. So published their data based on the 75% target that they reached. They did not show a significant difference in their primary outcome, which was death. They report a reduction in hospitalization, although the confidence interval of that reduction in hospitalization touches 1, so is not significant, and unsurprisingly high rates of side effects, which are predominantly diarrhea. The recovery trial also had an arm for colchicine. So again, in this case, a surrogate population, hospitalized patients, not outpatients, but again, including that group not requiring supplemental oxygen. And that study was, that arm of their study was stopped due to non-effect, not too long after COL-Corona came out. They've not published their full data set, but they did publish a summary, which showed that there was no significant change in death, progression to invasive ventilation, or duration of hospitalization. And as a result, closed the arm because it was felt that further recruitment would not change the findings. Remembering, of course, also with colchicine that there are harms like everything else, particularly the diarrhea, as was seen in Corona, as well as the renal impact drug interactions and the challenges of keeping it within a narrow therapeutic window. Corona also used a dose that wouldn't be available to us to prescribe, so I presume if we were trying to mimic it, we'd use the 0.6 dosage. But out of this, with one study with insignificant outcomes and one study, again, showing no effect, the recommendation would not be to prescribe colchicine to this population. And with that, I'm going to hand over to Ullanda.
Yes. Okay. So we know that vitamin D is implicated in immune function. So no doubt that we would start looking there. There was a study, it's observational, by Meltzer in the United States that looked at 4,600 individuals who had vitamin D levels measured a year before testing positive with COVID-19. And they found that specifically for Black people who had vitamin D levels between 30 and 40 nanograms per milliliter, which is the same as 100, less than 100 nanomoles per liter in Canadian units. So low levels of vitamin D. For Black people who had low levels of vitamin D, they were more likely to test positive for COVID-19 in the future. And based on the results of this observational study, they suggested that it would be a good idea to start looking at randomized control trials and see if vitamin D can help with prevention of progression of disease or prevention of infection outright. And we do know that people with darker skin have lower levels of vitamin D, as do the elderly and people who work indoors, maybe essential worker. And we do know that, for example, in Toronto, people of color are overrepresented in the number of cases of COVID-19. So these results could be quite important. So the trials have been happening. Let's go to the next slide. Our group looked at 3 randomized control trials. I'll do a deep dive into a couple of them for you today. For the SHADE study, it was small. It had 40 participants, 16 in the treatment arm. The intervention was 60,000 international units of vitamin D3 for 7 days. And the target was to get to a vitamin D level of 50 nanograms per milliliter. And the outcome measure was a negative SARS-CoV RNA, which our first thought was, is that a patient important outcome to have a negative test compared to something like reduction in length of hospital stay or need for oxygen. There was also another study that didn't have as, for the SHADE study, the results, it did reduce the SARS-CoV RNA negativity, but again, is that important? I don't know. The next study doesn't have a catchy name, but they looked at the effect of a single high dose of vitamin D3 on length of hospital stay. It was bigger. It had 240 patients. The intervention was 200,000 international units in a single dose. And they looked at some more important measures, such as length of hospital stay, need for mechanical ventilation, mortality, and none of these things showed a significant difference from placebo. Overall, all the studies we looked at had some issues with quality. They were generally underpowered and had some incomplete data or inconsistent use of important outcomes, for example, like with the SHADE study. And so currently, there's no benefit shown for the use of vitamin D for patients with mild COVID-19. That being said, there is minimal risk to having a low dose of vitamin D, and we continue to have this vitamin D indicated for bone health. And so Osteoporosis Canada, for example, recommends 400 international units per day for all adults over from 19 to 50 and over 50 to have 800 international units a day. So there's no harm in patients having an adequate level of vitamin D. But it also still makes you think, well, why did these observational studies show a possible link between vitamin D and COVID-19 infection and mortality? And I think that's kind of a question that a patient might poke you on. So in the chat, if you are able, can you postulate some ideas about why this link could be showing up in those studies? It's okay, not everyone is able to type. Oh, poverty. Oh, thank you, Kate. Any other ideas? Low vitamin D associated with obesity and other comorbidities? Absolutely. Yeah, so the issue is really about like comorbidities and other confounders, including socioeconomic status and thinking about the healthy, food insecurity, right? And also thinking about the healthy user effect. So someone who has vitamin D levels tested might have a better access to care. If they have a higher vitamin D level at baseline, maybe they have a better relationship with the healthcare sector. So in any case, the recommendation is not to treat treat COVID-19 with vitamin D in the outpatient setting. There are still some clinical trials ongoing. In fact, the group that did the observational study is still recruiting for their clinical trial in Chicago. So that's interesting to see, but so far the results say no. Next slide. Ivermectin. Oh, I love this headline. This was a gift to us. So Ivermectin hit the headline. And my folks who work with refugees and new immigrants will know this drug. It is used for human parasitic infections like strongyloides and onychorosis. And also it's used regularly in veterinary medicine. So let's go to the next slide. We reviewed 7 randomized controlled trials, and in total that was 751 patients actually had a mix of severities, so either mild disease or a mix or not specified. And the trials looked at both prevention and treatment. Overall, if we looked at them together, the studies were not the strongest in quality. They had few events, inconsistent outcomes, and a wide variation in the drugs that we were comparing ivermectin to. There was also a wide variation in the dosages used for ivermectin. It made it hard to generalize because it came from countries that are quite different from the Canadian population. And the control arms did not represent what our current standard of care is. So, for example, they compared ivermectin to hydroxychloroquine, which was a common thought at the time. Overall, there was no reduction in disease progression, hospitalization, and death with the use of ivermectin. And there were some important considerations here. The risk of drug shortages with the use of ivermectin could take it away from patients who actually do need it for parasitic infections. And the risk of side effects or toxicity, especially due to self-treatment, was very important because ivermectin is available for veterinary medicine. It's not that difficult to obtain. And so it could cause harm to patients if they think that it might help them with COVID-19. Overall, the recommendation is not to use ivermectin to treat mild COVID-19 infection. Next slide. Donald Trump got in on this one. We're talking about the monoclonal antibodies. So bamolivimab is the one that Canada bought $40 million roughly worth of. And I should point out that we're going to talk about monoclonal antibodies here, but I'm talking about the kind of antibodies that were created artificially from the antibodies that someone who had a COVID-19 infection, it's like a copy of their antibodies, right? So that's different than, for example, tocilizumab, which is a different type of monoclonal antibody that has a very different trajectory of evidence, which if we have time, we'll talk about a little bit today. So also, I should mention in that Toronto Star article there, it was actually based on case series. So in case your patient's asking, well, I have the article here. It's based on a case series, so it's not the strongest level of evidence. There are randomized controlled trials, which I'll show you now. Next slide. So the big one that is approved in Canada is the bamolivimab. One of the studies is the ACTIV-3 study. It was stopped due to futility in October. And the enrollment was closed with 326 total participants. And they actually were looking at moderately ill patients, but overall, it didn't show any benefit. The BLAZE-1 study was also a randomized controlled trial, 467 subjects. They used 3 different doses. And then their outcome measures were interesting. So they looked at viral load, which we're not sure how patient important that might be, and then hospitalization. But they termed hospitalization as ER visit with or without admission to hospital. We had some concerns about the study design, and the subjects were homogenous, so mostly Caucasian males. We also thought about the use of monoclonal antibodies in general, especially bamolivimab. It requires outpatient infusion capacity, which is going to be a particular challenge in where we're living here in Ontario. Since all those headlines came out, FDA has revoked the EUA because of concerns about variants being resistant to the monotherapy. And in fact, Health Canada has shown that particularly with the variant from Brazil and South Africa, and the one from California, sorry, I'm forgetting all the deltas and whatnot, but the newer name terminology, but the variant, the bamolivimab did not perform well. And they also note that these drugs may interfere with the vaccine response. So it is recommended that you wait 90 days before being vaccinated for COVID-19 if you receive this medication, especially during the time that we are in right now, where we're in a push for vaccines, and that phase of our story with COVID-19 would be a terrible time to make people have to wait. So our recommendation is clear: do not treat mild COVID with bamolivimab monotherapy. There is some interesting news still coming down the pipeline about monoclonal antibody cocktails. And so a lot of evidence is still emerging about them, and hot off the presses kind of thing will be coming down the line. I'll leave it there. And I'll hand it over to you now, Sumit.
Thanks, Ullanda. Good evening, everybody. So I guess going on with the Donald Trump theme, hydroxychloroquine was another medication that the committee looked at. So just to put this in context, hydroxychloroquine was found to be of interest early on in the pandemic due to its immunomodulatory effects, as well as in vitro data suggesting SARS-CoV-2 activity. Subsequently, actually, throughout the pandemic, it was found to actually have limited in vivo, especially in animal models, in terms of its impact on SARS-CoV-2. However, when we sort of zoom out and look at the published evidence to date, several RCTs have looked at hydroxychloroquine in the mild ambulatory population, both as outpatients as well as hospitalized. And this forest plot here is just showing the COVID-19 NMA initiative that looked at a meta-analysis of all these results that showed no impact on hard outcomes such as mortality. Next slide, please. Specifically, though, when we look at sort of the outpatient population and looking at other key sort of outcomes that are relevant to patients, such as symptom severity, Bulwer and colleagues, who have really sort of provided us with the evidence in the ambulatory population, looked at around 491 non-hospitalized patients who are randomized to hydroxychloroquine or placebo. And they found that there was no difference in symptom severity between the intervention and the placebo group. There were higher rates of adverse drug events, primarily GI, and during the time there was concern that supplemental medications that these patients may be on might have impacted the results, but when they did a post hoc analysis on that, they did not find any difference in those patients who were taking supplementation with zinc or vitamin C. Importantly, the relative risk symptom reduction in the hydroxychloroquine group was around 12%. To put that in context, oseltamivir, which is an antiviral that we use for influenza, is around 25%. So really there's a twofold difference. So really as a symptom management therapy, it has shown limited benefit. Next slide, please. Along with a lot of other things that we've talked about, these drugs are not benign. Hydroxychloroquine definitely has a robust adverse event profile, especially when it comes to high risk adverse drug events such as cardiac effects. And similar to other repurposed medications, when not used for its appropriate indication, there are obviously risks of drug shortages, which have been quite ubiquitous during this pandemic. So there's a clear recommendation from the working group not to use hydroxychloroquine in mild COVID-19 cases. Next slide, please. So antibiotics, this is obviously in my wheelhouse that I do on a day-to-day basis. Antibiotics has been of great interest during the pandemic, both from a targeted aspect for COVID-19, as well as a general class of medications for the perceived risk of co-bacterial infection in COVID-19 patients. In particular, azithromycin has been studied in COVID-19 due to its anti-inflammatory as well as its antibacterial properties. Both alone and in combination, particularly with hydroxychloroquine, it has shown no benefit in patient-related outcomes, including mortality. Adverse events have been associated, especially with other cardiotoxic agents, and its proarrhythmic mechanism of action. When we look at antibiotics as a class being utilized in COVID-19, co-infection in COVID-19 is extremely rare. The prevalence of bacterial infection when looking across studies is around 8%, and in ambulatory patients, it's less than 5%. The primary infections that we're seeing are secondary infections, and these are in hospitalized ICU patients where there is a higher rate of infections, but these are due to prolonged hospital stays and potentially other confounders. So there is a clear recommendation not to prescribe antibiotics for COVID-19 infections. Next slide, please. And this really sort of highlights the issue around what many have coined as the silent pandemic. So really the risk of the concurrent increased utilization of antibiotics during this viral pandemic is sort of the increased rates of antibiotic resistance. This is being primarily driven by changes in practices, the way healthcare is being delivered, as well as the increased use of empiric antibiotic use. Overall, the increase in utilization and the community spillover, the net impact is still unknown. Obviously, due to the sort of advanced infection control practices, both on the individual level in terms of mask wearing, as well as hand hygiene, as well as on the population level with the non-pharmaceutical interventions, this may have the net impact on both the transmission as well as the spillover of the antibiotic resistance is still unknown. However, we do know that AMR, antimicrobial resistance, is a lagging indicator. And with the increased use of antibiotics, so about 3/4 of patients who are hospitalized with COVID-19 have been receiving antibiotics. The anticipated community spillover is still real, and really it's something for us to keep an eye on. Next slide, please. So really, in the community setting, what can you do? Obviously, you're facing multiple challenges. Sometimes the COVID-19 status is unknown. There's quite a bit of diagnostic uncertainty, and this can be further exacerbated when you're providing care through virtual care settings. So there's this strong messaging about resisting the urge to prescribe antibiotics for respiratory tract infections, but really, what resources do you have available to you to help sort of navigate that? Choosing Wisely has put together a cold standard decision tool package that is quite useful in the ambulatory setting that can help navigate that. I know the COVID-19 working group is also working on something that's patient-oriented as well. But this example right here is looking specifically at the Choosing Wisely campaign, and really they're giving you guidance on how to manage respiratory tract infections, as well as red flags that may require more further workups, as well as referrals. There are viral prescription pads, which have been used previously to as behavioral modification techniques to help facilitate discussions with patients around other non-antibiotic interventions that can be used to help mitigate symptoms related to viral infections. Next slide, please. A few other things that have been looked at, aspirin, the rationale there was antiplatelet therapy to sort of mitigate COVID-19 associated systemic inflammation, as well as coagulopathies. Really, the biggest trial that just came out last week was the recovery trial, as Kate had mentioned. This was in hospitalized patients. However, a subset were patients who did not require oxygen. So there was about 5,000 patients in the recovery trial that was looking at aspirin that did not require oxygen, and there was no benefit on mortality or risk of progression. There continues to be trials of aspirin in the ambulatory population that have yet to make their results available. However, with the publication of the recovery trial, there is compelling evidence that aspirin does not have a role in this population. Convalescent plasma has also been looked at both in hospitalized patients as well as ambulatory patients. Really, in Canada, it's only available through Canadian Blood Services, and since the suspension of Concor 1, CBS has not been collecting any plasma from COVID-19 patients. So really, this treatment modality is not available either. Next slide, please. So as we're putting this talk together, we obviously didn't want to just sort of highlight nothing that's available. Rightfully so, there's been a lot of advocacy and a lot of editorial comment for the need for therapies in this patient population. Next slide, please. And really, what the importance here is to show that we want to sort of prevent disease progression as well as long-term complications in ambulatory patients. So far, the challenges have been in testing, really trying to detect those who are asymptomatic, as well as getting a clear picture of those who have clear risk factors for progression of disease. Part of the issues, especially early on in the pandemic, is that a lot of the therapies that focused on the ambulatory population were for repurposed agents with little emphasis on both preclinical as well as clinical development. And currently, a lot of the therapies that are available, especially on the Canadian market, they have high barriers of adoption, whether it be logistical challenges or intravenous administration, as well as extensive monitoring requirements. Next slide, please. So really, some of the agents that are being looked at are looking at how to sort of mitigate some of these logistical barriers, both in terms of routes of administration from an oral to subcutaneous formats, as well as looking at a broad spectrum of the disease states as well, both from direct antiviral activity as well as immunomodulatory therapies. A lot of these interventions are being tested through the adaptive platform trial out of the United States, run by the National Institutes of Health, known as ACTIV-2. And we're hoping to see some of these results in early to late fall. As some of you may have seen earlier last week, molnupiravir, which is a direct antiviral against SARS-CoV-2, got some significant headlines with funding from the U.S. government for a few 100 million doses, and they're anticipating to be providing their phase 3 results in early fall as the sort of a directed oral antiviral against SARS-CoV-2. So those are a few things that we have to look forward to in this patient population. And with that, I'll send it over to Brad.
Great. Thanks so much, Sumit, Ullanda, and Kate. That was great. This is just a quick summary slide of many of the treatments that we had just discussed. And it includes our science table clinical practice guidelines recommendations for each of those medications. Of course, this is always changing as new information becomes available. These are our current recommendations to date, but we do keep it up to date, and we'll keep an eye on the literature as it progresses. We do hope to make this available as well as some additional resources. And these will be posted on our website in the near future on the Science Table website. So in conclusion, from what we've heard so far, there are really currently no drugs that have strong evidence in favor of managing mildly ill COVID-19 patients. Many of the studies are small and have a low quality of evidence with a high risk of bias. And some of the medications, as you've heard, have capacity for harm that outweighs the potential benefits. But there's still some hope. We have many studies that are underway with both new and repurposed medications. And in the meantime, with the lack of strong evidence for medications in mildly ill COVID-19 patients, that really helps us to reinforce what we do know is the importance of non-pharmacological and public health interventions, particularly vaccination, for preventing COVID-19 in the first place. So before we close, a plug for a couple of helpful resources in Canada. The first is a link to our Ontario Science Table website. There you will find some up-to-date information and summaries from as well as COVID-19 evidence summaries on a variety of topics, ranging from vaccination to drug therapy to health equity. And do keep an eye on this website in the coming weeks for some new resources, including related to today's topic. Science Brief will be addressing many of the medications that we've discussed today. As well, we will have some resources that will be geared towards the patient population that you can help to provide to your patients who do have questions about these medications. So this concludes the presentation component of our webinar, and we do have about 12 minutes to answer questions. So I'll open it up for questions, and we do have some in the chat box, but keep adding your questions. In the meantime, I do have a question that I will ask that came in through email prior to the presentation. And this question is for COVID-19 patients who have mild illness, who are going to receive a one-time monoclonal antibody infusion to avoid hospitalization. Where will this likely occur, and who will pay for the drugs? I'll turn it over maybe to Ullanda first, and see if others want to jump in as well.
So yes, like I mentioned earlier, the approval is for an IV infusion. So that's going to be a hospital situation, most likely. And now, looking at the evidence and the prevalence of variants in our population, there's no benefit for mildly ill patients.
Thanks so much. Any other additions that other panelists wanted to add?
Yeah, no, I think Ullanda is right. I think currently all the antibodies are primarily infusion based, so they'll have to be. If we look to our neighbors to the south, most of them have been done through infusion clinics that have been set up through the hospitals. There have been some push towards finding other formats like subcutaneous formulation, and some of these newer monoclonal antibody cocktails are looking at the subcutaneous formulation, but none of them have been approved in Canada. I guess in terms of funding, that's still an open-ended question. I guess if we were to look at some of these newer therapies that have been approved in Canada, the federal government did take a role in procuring it for the country and then distributed it to each of the individual provinces. I don't know if that's going to sort of continue on with these monoclonal antibodies, but that might be one of the ways that it's provided to the provinces.
Thanks, Sumit. Our next question is, are some of these resources and links available on the CEP Center for Effective Practice and COVID resource page? And my response, I believe, is that they are not on that page. You can access them through the science table. If you Google Ontario Science Table, you'll find most of the resources that we've discussed there, as well as some forthcoming resources that will talk specifically about COVID-19 and mildly ill patients. But I know that CEP provides some great resources, for example, on vaccination and helpful handouts and tools for prescribers as well. But if you do have any insights on how we can get our resources linked from CEP, let me know. I'm happy to chat about that.
So I think that the CEP's focus is on quick clinical evidence and documents. So for instance, the science advisory tables, VIT, the blood clotting side effect from AstraZeneca resources are linked there. I'd anticipate that some of our patient-facing resources, if we're able to launch them, would be linked as well, but they've steered away from some of the more scientifically based, more specific hospital-based ones, such as the majority of the science briefs that are there. But I've gotten in with CEP. I'll do what I can, Brad.
Awesome. Thanks, Kate. And Ullanda, earlier you had mentioned tocilizumab. Did you want to add any information about tocilizumab as it applies to this patient population or in general?
So there's no evidence to use tocilizumab in mildly ill patients. However, the science table has reviewed and recommended tocilizumab for use in moderately ill and critically ill patients. And the details of that are included in our resources that I've linked. I put a link in the chat there for you. But that's for hospitalized patients who are requiring oxygen and basically who have already received a trial of dexamethasone. Am I correct, Kate? Did I say that right?
Sorry, yes, you're correct. So it's patients who continue to worsen after 24 hours of sufficient anti-inflammatory and dexamethasone or equivalent. I think the other important thing for the outpatient population around tocilizumab, and Ullanda did mention it, but it bears repeating, that when it comes up sometimes for me in vaccination clinic around people who've had COVID and are getting vaccinated post-recovery from COVID, whether or not they've had a monoclonal antibody, because that would be a contraindication to vaccination just for lack of effect rather than risk. And so there's sometimes some confusion about whether TOCI qualifies there or not. It does not. It is the targeted neutralizing antibodies, the monoclonal antibody cocktails that are contraindication with vaccination. And because the only approved ones in Canada right now, bamolivine is not being used, and apparently a Regeneron cocktail was just approved last week, but is not yet available. At this point, it's safe to say that a hospitalized treated patient did not receive a drug unless they were in a study that would be a contraindication to vaccine.
Thanks, Kate. I'll give a last call for any questions. I believe that kind of answers the questions that are currently in the chat box, but please feel free to add anything further. Not seeing anything there. I think it is 7:55 and we can perhaps leave about 5 minutes early. Again, I want to thank the presenters for their excellent work in laying out this information very clearly in a very insightful fashion. Also want to thank the audience members for attending and taking the time out of your evening to learn about these medications. And also thanks so much for all that you do to care for patients with COVID-19. Thanks everybody and have a great evening.